I'm going to give a talk today on PSMA PET scans, Theranostics. I'm going to talk about SPECT and a glimpse of the road ahead in prostate cancer. So that's a whole bunch of things to cover. And a little bit about me, I'm a nuclear medicine physician and radiologist. So I think you guys know what a radiologist is. We do with CT scans, PET scans, SPECT scans, MRI, all the kinds of stuff. But nuclear medicine folks might be unfamiliar to you. And what we do is we deal with radioactive drugs. And we do it for both imaging purposes and for treatment. So we're going to talk about a bit of both of those things. But the main thing I want you to come out of from this talk is that we're all in this together. You know, I'm a technology guy. I love technology stuff. I like the cool gadgets. You know, I have a training from MIT in the background and a PhD and all that good stuff. But at the end of the day, I'm a physician and I'm also a cancer survivor. My father, my father-in-law both have prostate cancer. So we're in this together and we'll get through it as a team. So I do have some disclosures here. I do get research funding from a number of different companies. I do consulting for a number of different companies in the radiopharmaceutical or radioactive drug space. I take all that money, I put it into research. I do hold patents and Mayo holds patents. I have my own PSMA targeted imaging and therapy technologies we're developing. And I am going to talk a little bit about things that aren't FDA approved, just to give you a hint of what's coming in the future. And I'm also a founder of several companies, including Nucleus Labs, which is in the production of radiopharmaceuticals for imaging and therapy. So where are we in the field and historically, and where are we going? So historically, we did a lot of work with what we call conventional prostate cancer imaging. So bone scans, which is a nuclear medicine scan you may be familiar with, we give a radiotracer into the body. It goes to places where the bone is injured and shows us where cancer might be. And you see the bone scan here of a patient's bones. CT and MRI are standard or conventional imaging by comparison to what I'm going to talk about later. A CT scan, as you see here, is an image of a patient with an X-ray shooting through them. And it's a shadow of the X-rays, and it shows you dense things like bones. These are the patient's pelvic bones, and here's the bladder, and down below that would be the prostate. Whereas an MRI, I think of as pretty advanced, but we still call it conventional by comparison to PET scans, are really good at looking at soft tissues. And here we're looking at echoes of magnetic resonance bouncing out of the body. It's pretty cool stuff. But you can see right there on the bottom, this is the prostate gland right here. And in this image, we might be looking for an early prostate cancer. So what's a PET CT? Well, I like to describe it as two halves of a bagel. You got the scanner on the left, you lie down on it. It looks like any other scanner you've got, but it's really two scanners in one. And they're two halves of a bagel put together. One half is a CT scanner, just like we saw before, where the X-rays are shooting through you and it creates shadows and we can see the anatomy, we can see structures, we can see tumors. A PET scan is different, and we'll get into that in a little more detail, but a PET scan is the back half of the scanner. And that's the part where the magic of what I do really comes in, where we're looking to see where a drug we injected in you went to find your cancer. So as I mentioned before, my father's a prostate cancer survivor. He's also a Vietnam vet. And so when I'm trying to describe this stuff to him, he says, okay, you said you're injecting a radiotracer. And he's like, is that like a tracer round in the military? As you can see here, they're shooting off flammable bullets that light up the sky to show you where the bullet's going. And in a way, that is kind of what a radiotracer is. It's kind of the wrong concept because the bullet actually hits somebody and hurts somebody, whereas the radiotracer is almost harmless that we're using for the PET scanning. But a similar concept in that we're tracking where it goes in the body because it's giving off signal to us in the form of radioactivity, not light, but a different kind of invisible radioactivity. So what is a radiotracer? Well, it's radioactive. That's the first half of the word. It's trace, meaning a very, very small amount that we're injecting. So a small amount of dose. And we can image or bind it to a very, very small amount of a target. So even if there are very few cancer cells, we can often see them. The word trace has a double meaning. It also means find by investigation, which is where the tracer round comes in. But if you look at, how much are we injecting? Some people get nervous about radioactivity. You're injecting me with radioactivity. Well, it's a very, very tiny amount, and the kind of radioactivity is very harmless or near harmless. If you look at this finger here, they are granular particles of sugar. If you cut one of those 1,000 times, that's how much drug we're injecting, 1,000th of 1 grain of sugar. And the radioactive component of what we're injecting is 1/2,000,000th of that. So most of what we're injecting is just the part of the drug that gets it to the cancer and sticks to it. The radioactive part is really tiny. So what do? We inject a radioactive drug or radiopharmaceutical into a vein. So you can see here, it goes throughout the body. It's designed to stick to cancer. And what doesn't stick, we want it to get out of there. We want it to get out of your body immediately. And mostly it comes out in your urine. So here's an example, kind of diagram of that. If you have a cell of cancer, on the surface of the cell, there's a molecule there that we're targeting that the cancer cell has all over it, but the other cells in your body don't. And so we design a molecule that sticks to that fits perfectly and binds to that surface. That's called the ligand. And this is the PSMA part, which we'll talk about later. Then there's a little bit of a linker, and there's a special thing to hold on to a radioactive atom. In this case, gallium is what we're using here, gallium-68, which gives off a signal to our PET scanner. The cool thing is the second part of the talk I'm going to talk about is once we've identified that you as a prostate cancer patient have cancer that we can see with this kind of imaging, then we know whether or not we can treat it. So we can actually take that gallium radioactive atom here and replace it with a different radioactive atom to try to kill the cancer. And that's really the cool part of this technology. So what does the word emission mean? Well, when this radiotracer goes into the body, so that those little red blobs are supposed to be a molecule of this drug that we've injected in. At some point in time, it's like a ticking time bomb. It just gives off a positron. That positron is, I know that I'm a dork with science stuff, but it's antimatter. It's literally the opposite of matter in every way, especially the charge. That then hits an electron within a millimeter or so of where the radiotracer is, and it gives off these beautiful 2 photons. So they convert the positron and electron into pure energy. They shoot through the body without interacting with the body much. And those 2 photons fly out on a straight line, okay? So I haven't lost you yet. I'll get you to the end here in a minute. If this is a person inside a scanner, these are the detectors around the patient, okay? Those 2 photons fly out and hit the detectors, and it knows that somewhere along that line, that radioactive drug is in the body. But now, the scanners and the technology are so fast that at the speed of light that these photons are flying through the body, it can detect which one hit first. And it can mathematically, we can figure out, okay, not only did it come along somewhere along that line in the body, but it actually came in that little 2-3 centimeter area, and we can really more accurately pinpoint exactly where the drug is in your body. So what does that give us? Well, it gives us a scan. So PET stands for positron. That's that thing our radioactive drug gives off. Emission, which is the light that shoots out of the body, the light that we can't see, or radiation. And tomography, that's the T in PET. Tomography comes from tomos and grapho, slicing and imaging. So I like to think of these as like slices of bread. So I'm going to show you some images in a minute. And as we scroll through the images, think of it like going through slices of bread, but the bread instead is your body, okay? So this is a PET CT. It has a CT and a PET combined. We use the CT and the PET image together. So we get a CT image. This is a patient standing up. You can see their head at the top and their arms. You can see their heart right here and their lungs. This is the PET scan sliced vertically, what we call coronal view. You can see their brain here. This happens to be a glucose radiotracer, and the brain consumes a lot of glucose. It lights up. So this image is created. We then take the CT to make the PET scan better. So because those photons are flying out of the body, sometimes they hit bones and things and they don't come out. So we have to adjust the scan. We have to correct it, attenuation correct it, to get this beautiful map of all of the drug in the body, the radiopharmaceutical or the radiotracer. The image is actually our best guess at how much radioactive tracer is in each part of the body. That's what it is. That's what the image is. Whereas a CT scan is our best guess at how dense each part of the body is. So bone is more dense. Then we put the two together. We actually take this black and white image of the PET scan, we turn it into color. And the reason we do that is because we're going to put it on a black and white CT and we want to be able to see the two of them. So we choose to have a rainbow color. Some people use red or green or other colors, but you can see the colors on top of the CT scan, and that's your PET CT. So when we do them together, it lets us co-localize. What does that mean? It means that if I'm looking at this image, this is actually a three-dimensional image of exactly where a radiotracer is in a patient's body. And that thing where the arrow is on a tumor. It's not supposed to be there. That's not normal. But where in the body is it? How do I tell the surgeon or somebody else to go in after it? Well, now I've got an image of a patient. Imagine their feet are coming out toward me. This is cut right through this slice of the body. You can see the PET scan here in that slice. You can see that focus right there. This is the CT co-localized. I can see this is the clavicle bone here. This is the spine. These are ribs. That's the shoulder. You can see, well, that radioactive drug, that radiotracer is right behind the clavicle, and it's right inside this little piece of density. That's a lymph node right there. And I can tell the surgeon and the radiation oncologist exactly where it is. There it is. Okay. And then we measure an SUV, which is it's a measure of how much drug we think is there. And the SUV is very high, which means a lot of it went to that tumor. So here we have what I actually look at when I'm sitting in the reading room and I'm looking at a scan and I'm saying, okay, I've got Mr. Smith. He's got 65-year-old. He's got prostate cancer in the past. And I'm trying to find where it is. Okay. And here is this tiny little ditzel down here. I see, well, maybe that's of concern. Well, what about these little things here and here as I'm kind of scrolling through? Okay, well, there's his bladder. I can see his bladder, and right below the bladder should be the prostate. So I scroll down there and I'm like, okay, the prostate's gone. In fact, I can see all these little surgical clips. Okay, you see them on the CT scan here. Surgeon's been in there. There's been radiation done. All I'm seeing here is urine. The radiotracer that doesn't stick to the tumor, we want to get it out of the body. And most of it comes out in the urine. And so you see all this activity in the urine that's normal. You can actually see it flowing from the kidneys to the bladder in the ureters here. So the kidneys are clearing it out. They've got a lot of activity. As I scroll through here, I'm looking, I see, okay, there's the spleen, there's the liver, that's normal. I start looking at different ways to look at the CT and any lung nodules. Basically, I'm looking through this whole scan and I'm thinking there's nothing there except for that one little ditzel I showed you before. It turns out that's a red herring. That's a little nerve bundle that people sometimes get confused on. So in this PET scan, we're pretty sure the patient's cancer has come back, but we don't see anything. So that sometimes happens. So I'm showing you this first. I'm going to actually open up this image and show you what a three-dimensional image looks like. So this is a scan of the patient. I'm going to rotate it around. And if I make it really dark, you can see the outline of the patient. You can see their arms, you can see their legs, okay? This is what a PSMA PET scan looks like. This radiotracer is designed to stick to prostate cancer. I normally see the glands that make the tears, the salivary glands, these are the parotid. I see the liver, the spleen, the kidneys, some of the bowel, it's all normal, and then the ureters, and there's the bladder. That's all normal. I'm not actually finding any cancer in this patient. Okay, now I'm going to flip to a patient who has active cancer on the scan so you can see the difference. All right, so as we scroll through this, now you're seeing all these dots, all these hot spots that weren't there before. Okay, we're seeing them in lymph nodes in the posterior of the belly along the spine. This is the aorta that brings blood from your heart to your body. Those are all sites of cancer. All of these spots, like this one here, those in the bone are abnormal. And you can see on the CT scan right there, see how it's whiter right there? That's sclerosis. So if the cancer has been there long enough, most prostate cancer becomes sclerotic. So we can actually see some of these cancers on the CT scan, but I can't tell on the CT scan if the cancer is alive or dead. You know, maybe a prior therapy treated it and that's just been sitting there and there's no cancer cells there. And that's just healed, dead sclerosis. No, it isn't, not in this patient, because the radiotracer is sticking to the cancer cells. It tells me that the cancer is alive in that location. And as we scroll through, you can see in this patient, there are even an unusual situation. I'm going to change the window level so you can kind of see it better. They have metastases in the liver right there. Now, if I try to see that on the CT scan, I can't see anything there. There's nothing there. So the PET scan is letting me see things I can't see on a regular CT scan. I'd have to do special things like add contrast or do an MRI to pick that out. Okay. And if I bring up the MIP image, like I showed you before, the three-dimensional rotating image. So I bring up the MIP image, and now you can see all of those tiny little lesions. And I'm going to bring this patient scan up again several times so you can see, and later on in the exam, in the lecture, you can see all these little dots. These are bone metastases, lymph node metastases, and liver metastases. So this patient, I look at them and I say, this patient might be a great candidate to use a different version of this drug for therapy. So as was mentioned before, we can then put lutetium in the same compound, and then it's lutetium PSMA 617 or Pluvicto therapy. And that second patient might have been a great candidate for that therapy. I'm going to step back in history a little bit. You guys have seen lectures on the same program from Eugene Kwon, great friend of mine, a collaborator. Val Lowe, who works in radiology, works with me. The two of them brought forward C11 choline, which was a radiotracer designed for imaging prostate cancer. We've been doing this since 2005 here, together with Dr. Joseph Hung, who's a nuclear pharmacist, and Mark Jacobson, a PET radiochemist, brought that through the FDA, got it approved so that we could find cancer hiding in people's bodies. And here's an example case. This is a patient who had prostate cancer. It was surgically resected, and it came back. PSA was just ticking up to kind of 0.5. And you can see this tiny little lesion here, 5-millimeter lymph node tucked in near the lumbar spine, near the muscles that make the legs move, the iliopsoas, right near the blood vessels, that tiny little ditzel. You'd never pick that out on the CT, and that was the only metastasis in the patient. But now we're moving on to PSMA imaging, and so that's what we're going to talk about next. There are two different drugs that are new in imaging prostate cancer in PET, gallium PSMA 11 and F18 PSMA DCF-PYL. It goes by the trade name Polarify. At the end, I'm going to talk a little bit about these two. These ones are all historic. I mentioned, you can use glucose, you can do a bone scan, you can use choline, and then there's another one called fluciclovine or oxamin that you can use to try to find prostate cancer. But the most excitement is around PSMA, and PSMA is the only one that can be converted to a therapy. So here are some scans. Now, I showed you PET CT before, but we can also do PET MRI. We've had quite a lot of fun with this. It's very popular, especially patients who are early on in their disease where we're trying to see it in the low pelvis. We can see little ditzels like this diffusion-weighted bright spot or ADC dark spot that looks concerning. And then, oh yeah, it's also got PSMA activity. The radiotracer went there. And oh, by the way, that little tiny lymph node that looks totally normal in the MRI, it's glowing hot on the PET scan. And so now when the surgeon goes in, they're not just going to remove the prostate, they're going to go after that lymph node. Here's another example. This is a patient who had surgery and radiation before. Their PSA starts going back up. We're like, where is it? What are we going to do? And on PET MRI, we can see a tiny little lymph node here and a lesion in the bone. The bone looks different on MRI. I don't know if those are alive or dead based on the MRI. They look kind of concerning. They're showing some enhancement. But here they're clearly glowing on PSMA. They're alive tumors. And those were the only metastasis in that patient. They went ahead and radiated that patient to control their cancer. So what is PSMA? PSMA is prostate-specific membrane antigen. That's the name it got back when they were studying it in the lab, okay? But it's not exactly 100% prostate-specific. It is a membrane antigen, meaning it's on the surface of the cells. That's what membrane antigen means. So this is a cartoon drawing of what it looks like. If this is the edge of the cell membrane, the edge of the cell, this is the part sticking out into the tissue fluid and blood where the PSMA drug would stick to it. It's got a bunch of names in the literature, but the key part here is that it gets upregulated. What the heck does that mean? That means that when the prostate cell becomes cancer, most of the time it upregulates or expresses or has a lot more of this on its surface. So yes, the prostate cells themselves have PSMA on their surface, but the cancers tend to have 100 to 1,000 times more of it on their surface, which makes it great as a target to try to find the cancer. And as we discussed before, this is what a normal scan looks like. We see these normal structures. I showed you one nervous glia, nervous cluster of nerves down the pelvis that could fake someone out into thinking there was prostate cancer. There's also some things where we see some other kinds of tumors. Some kinds of tumors, when they grow their own blood vessels inside them, and those blood vessels can express PSMA. So when we read these, it's not so simple. I can't just say that has activity, that's cancer, or that is bright, that's cancer. We have to think about what are the other imaging, what's the MRI look like, what's like the CT look like, is that truly a cancer that we're looking at? So I'll give you some examples. PSMA expression, so in other words, as the amount of drug, radioactive tracer goes to the tumor, the brightness goes up on the image. The higher it is, the worse prognosis or the worse kind of cancer the patient has. And it can vary between patients. And even within a patient, they can have tumors that are PSMA expressors and PSMA negative. So there's a lot that we're learning as we go through all of this. One of the nice things is, as the tumors express more PSMA, our therapy works better too, because we get more therapy drug to the tumors. So I'm going to skip that one. I'm going to show you some cases here. This is our first patient case. And you can see here that this patient has one focus of activity right there in the seminal vesicles. These are the glands that make the semen. And unfortunately, that's where it regrew. And we can see that spot very clearly. Okay, can't see it on the CT. Here's another patient. See this really, really tiny spot right in front of the spine down there. I look at the CT, I can't even see anything there. Now, you have to recognize we do the CT first, then the PET scan. Sometimes the patient moves a little between the two. So if I scroll up a little, there's a lesion. That thing is 2 to 3 millimeters in size. I mean, we're talking about like less than 1/10 of an inch that we're able to pick up with this technique and say that that's an active site of cancer. Here's another one, a really tiny lymph node there of about 4 millimeters in size. Here's one that's not so hot. It's, mildly avid, as we would say. It's not glowing as brightly. There's less drug getting to it. Some cancers don't express as much, but that's also a site of cancer. Here's a patient with little tiny mets all over their body, all over their bones. And this patient had a negative CT scan and a negative bone scan, just to show you how much we can miss when we're looking at patients with our conventional imaging compared to this advanced PET scanning. Here's a patient with a lymph node up in the neck of prostate cancer, okay? There it is, tiny little lymph node. That was the only site of cancer we found in that patient. So sometimes it's really far away from what we're used to looking at, but that was the only site of cancer. And you might say, well, what's that little ditzel over there? I see a little hotspot on the other side. Okay, I can see it there on the slice through the patient again. And what is that? Okay, there's our metastasis, and there's that smaller, less bright lesion. Oh, there's one on the other side. Those are ganglia. Those are normal structures. So we see those, they have some PSMA expression. They're just normal nerve cells. And the people reading the scan have to know how to read these to not confuse these things. You can see them again as we scroll. And there's a patient who has, these are all little ganglia going right down the spine. So as the nerves come out, these little nerve root clusters can light up on the scan, and you don't want to have your physician confused by that. Here's another one. This is a patient who has a tumor in the spleen. This is an organ that kind of cleans out red blood cells that are dying and keeps the blood clean. Prostate cancer really doesn't like to go to the spleen. It would be very rare. So we see this and we're already thinking that doesn't make sense for prostate cancer. And then we looked back at old scans, and this lesion has been there for a long time. It's not changing. We could see it on an MRI scan 5 years ago. This is what we call a hemangioma. It's a benign tumor. And this goes back to what I said before about sometimes the vessels, the neovasculature or the endothelium along the blood vessels in some tumors can express PSMA, and it's not prostate cancer. Here's a similar lesion. This is a benign lesion in the bone that looks kind of concerning on the PET scan, but it's fibrous dysplasia. It's a benign lesion that's not going to change. It'll be there forever, and it was on this patient in imaging going back a long time. So we can ignore that. Then you've got a lesion like this. You've got this tiny lesion up in the lung. This is the only lesion we saw on this patient. You look on the CT scan, which was part of the PET CT, I don't see anything there. We then brought them over to a regular diagnostic CT scanner. A diagnostic CT scanner is a better scanner than the CT you get with your PET scan. And there you can see this really, really tiny little ditzel there. They surgically went and took that out. That was the only site of prostate cancer in this patient. It was that tiny. Okay, so I showed you a bunch of imaging. I give you a hint that we can use this therapy to this imaging to direct which kind of therapy we're going to choose. I also said we can use this imaging to select a patient for Pluvicto or PSMA targeted therapy. But what about using the amount of activity at the initial time of diagnosis? In other words, we have a patient coming in, Mr. Jones, he's got concerning prostate cancer on a biopsy, and we're concerned that it may have spread beyond the prostate. We want to know whether we should just go ahead and do surgery or whether we need to image him with a PSMA PET scan. And so there are certain classifications. We can go ahead and do a PSMA PET scan on a patient who has not had any therapy yet to identify whether they need something more than just regular surgery or radiation or ablation. We select those patients, and when we get the scan back, one of the things I do is I describe how much activity is in the tumor, because that then also helps people figure out how aggressive to be. And so we have this thing called the PSMA expression score. There are a number of different ways we can describe a PSMA PET scan to try to convey, how much of the drug went to the tumor. And the PSMA score is probably the simplest one, and that's what we've adopted here at Mayo. So if you compare a tumor to the normal structures in the body that have PSMA activity, then you get a scale, 0, 1, 2, or 3, 3 being the highest. The parotid glands, or the salivary glands that make saliva, they have some PSMA expressed on their cells. They're the hottest structure in the normal body. So if the tumors are hotter than that, have a higher SUV than that, we call it a 3. Those are the patients who have usually higher grade tumor that we're more concerned about. They also, if they're going on to therapy, are the ones we think will have the best response to a PSMA targeted therapy. But for the purposes of dealing with surgery, right at the beginning of dealing with prostate cancer, this score says I'm more concerned about the patients having the cancer come back after surgery if the PSMA score is 3 rather than 1. So the liver is another cutoff, and the blood pooled background. So I'll show you some examples. Here is a patient. This is their MIP image. There's no metastatic disease. On the CT scan, this is the prostate right here. You can see that there's just a blush of activity in the prostate. This is the PET scan here. Okay, this happens to be the rectum back here. These are the pelvic bones around it. So that's a low level of activity. That suggests that the patient has a low risk of having recurrence at a later date. Okay, it's less hot than liver, more hot than blood. Here's a second patient example. This is a patient, again, we've got the prostate right here. We've got a little tiny focus right there that's pretty hot. Okay, this has a PSMA score of 2, which means it's hotter than blood and hotter than liver as an internal comparison. There it is on the MIP image. You can see it below the bladder, which is the bright thing here. And there's the liver for comparison. It's hotter than liver, but it's not as hot as the salivary glands. So it's in that PSMA score 2. PSMA score of 3 is the hottest category, the highest. And here you see a patient. Here's the prostate. This is the bladder kind of peeking in here. That's just urine. Don't worry about that. But this is a very, very avid or bright tumor with a lot of PSMA radiotracer in it. And if I rotate the MIP, you can't really see it because it's behind the bladder. So if I rotate the MIP, now you're looking at the patient from the side, you can see this elongated tumor in the prostate gland back there. Okay, that's hotter than liver, hotter than salivary glands. This is the hottest. This is the patient we're most worried about recurrence. Luckily, the PET scan didn't show any metastases in that patient. Okay, so hopefully that makes sense about a PSMA score, because you'll see that on your PET scans if you're getting them. So there are 2 drugs, as I mentioned, and they're roughly equivalent. I'm going to show you some images here. So on the left side, we've got a MIP image, we've got a CT, a PET, and a fused image. In this case, the color scale is red. On the right, we've got a kind of a side view of the patient. So a sagittal view, you can see down the spine, you can see all these little mets. There's the PET, there's the fused PET CT, and there's the MIP. One of these happens to be one version of the radio tracer, the other is a different one. And I got to tell you, I can't tell the difference. If I'm looking at the images, I can't tell which radio tracer was used unless you tell me. This one happens to be the F18 one. This happens to be the gallium PSMA 11 one, okay? And this one and this one are both FDA approved. One difference is right now, because the therapy trials used this one to select patients, the PSMA 11 to select patients for therapy, some insurance companies require that you get this version of the scan prior to your therapy, which is an interesting one we can talk about. But they're both equivalent, and we're hoping that that will go away and you can use either one interchangeably. In fact, a whole group of societies got together and basically said, there's no evidence there's any difference between these two radio tracers. The PET scans are equivalent, and insurance companies should view them as completely interchangeable. And we hope that that will be the case coming forward. If you look at the structure of them, they both have the exact same site of binding. So in other words, you can't, for those of you who aren't chemists, can't tell, but this structure and this structure are identical. In other words, the binding site of how it sticks to the cancer is identical between the two. So over the last couple of years, these have gotten approved. A big shout out to UCSF and UCLA, like Mayo did back in 2011 when we got choline FDA approved. They went out as an academic institution, both of them, and got PSMA imaging approved. Then two different companies, Telex and then Novartis, came forward with kits that allow other places to make it. And then the PSMA DCF-PYL, otherwise known as Polarify, that's made by a company called Lantheus. So for your purposes as a patient, do you care which one you got? I would suggest to you, you do not. It shouldn't matter. And if you got your insurance company to pay for it, go get the scan, go get what you need. And the details are between the two are minuscule. Okay, I'm going to talk a little bit about how we make the radio tracer, because I think you may find this interesting. So we get this box. We actually make this PSMA 11 at Mayo. And we get this little box that comes into our PET radiochemistry lab that's called a generator. It has a radioactive precursor, and we just kind of pull gallium off it. Gallium kind of spills off it, and we wash it off. Every few hours, we can get another batch. We put that gallium into the PSMA drug, and then we can inject patients with it. So where does the generator come from? Okay, it actually comes from a nuclear power plant or a nuclear reactor. Okay, so it is not inaccurate to say that we are heavily purifying, but using nuclear waste in a way to help us identify and treat cancer, which is very cool. So germanium comes from that goes into the generator. We then make the drug. Very highly regulated, very safe, but a great way to use these resources in a different and interesting way. We came up with at Mayo a different way to make gallium, which is the radioactive atom, with what's called a target. We patented this, we've licensed it, and there are other versions of this coming. But basically a different way to make gallium where we don't have to use or worry about the supply and how much availability there is of generators, because the generators, there's a limited supply, which is causing problems in terms of people getting PET scans. So we put that onto a cyclotron, which is this machine, and we have several of them here. So high-tech stuff here. I love this stuff. I hope I don't lose you guys. We spin subatomic particles up to 1/3 the speed of light in a circular manner, and then we slam them into that little target, and we create new atoms of radioactive gallium in this case. And then we use that into a lab. This is one of our labs here. We got all these fancy shielded areas where we can work with large quantities of this stuff, get it down to a really tiny amount that's purified, FDA inspected, everything you can think of as a drug manufacturer. And that comes from a lab like this into the patient for the scans. Okay, so in prostate cancer, if we go back to 2013, we already had a radiopharmaceutical therapy, a drug that was radioactive we could use to treat prostate cancer. We still use it. It has some limitations. It was approved in 2013. It's called Radium, or Xofigo is the trade name. Does it work? Yes, it does. What's the problem? It only treats patients who have prostate cancer in their bone. If the prostate cancer has left the bone to lymph nodes or liver, like I showed you before, if it's still in the prostate, it will not treat them. It actually binds to the bone where the bone is injured and then radiates the prostate cancer cells nearby. So it's effective, but has some limitations in its use. If you look at, what kind of therapies are there for radiopharmaceuticals? Well, we've got ones for thyroid cancer. We've got ones for lymphoma. We've got ones for liver disease that we inject into the arteries and they stick in the blood vessels. We've got ones for neuroendocrine tumors like pancreas cancer. But the biggest area of growth is in prostate cancer. And the biggest target that people are excited about is PSMA, like we're talking about. So these are some of the ones we're working on at Mayo. I crossed this out because this one, that trial closed. It didn't work very well. And if we look and say, okay, who does this kind of therapy? I'm a nuclear medicine physician at Mayo Clinic in Rochester, Minnesota. I'm the one, and my colleagues are the ones who give the therapy, but we work as a team. We work as a team with our medical oncologists, our urologists, our radiation oncologists to decide what the best therapy is for any given patient. Because we know a lot about radiopharmaceutical therapy, but we know less about other therapies that are good options, and we work as a team. At some institutions, the nuclear medicine physicians aren't the ones giving the therapy, such as PSMA targeted therapy. Sometimes it's the radiation oncologists who do it. Sometimes it's medical oncologists. Sometimes it's urologists. Rarely it would be an interventional radiologist. So they all, in different institutions, may be giving the therapy. And it does make it interesting. Our group has worked really hard to get this cohesive team behind each of our patients to come up with the best plan. Other groups haven't quite figured all that out yet. And now that this therapy is becoming so popular, they're trying to figure it out. And I think they'll get there, but there is some learning going on. It's definitely an opportunity for developing a multidisciplinary center of excellence. And the Society of Nuclear Medicine came out with some guidance and some accreditation this year actually. And we were very happy. Dr. Tuba Kendi in our group is under me as the chair of the division. She's the lead of our therapy practice in nuclear medicine. And we submitted and got the highest level of therapy center of excellence called the Comprehensive Therapy Center of Excellence. And some of the things that they want is an integrated team. They want to know that you've got research trials going on, that you know how to do that, and you have sufficient resources. For example, we have 23 rooms, both research, inpatient, and outpatient, where we can do these therapies. Okay, I'm going to pause for a second and talk about terminology. I want you guys to understand that the language around this kind of PSMA therapy is extremely confusing. So what are some of these terms? Theranostics is a term you'll hear. That's the concept of diagnostic imaging and therapy as a pair. So theranostics. So PSMA for imaging, PSMA for therapy would be a perfect example of a theranostic approach to treating cancer. Some people will call it radionuclide therapy. Targeted radiotherapy, that's actually a term that radiation oncologists often use, which we then joke in nuke med saying, well, isn't your external beam radiation targeted? But in reality, what it is an abbreviation for molecular targeted radiotherapy. And then there's targeted alpha therapy, which is kind of a next generation with an alpha emitter, which if we have time, we'll have a moment to talk about. Radioimmunotherapy, or RIT, that's specific to antibodies. If we use an antibody to stick to the cancer and make that radioactive, then radioimmunotherapy is a term that applies. And an example is one of these ones we have to target lymphoma called Zevalin, which is an antibody. It's basically taking the immune cell's ability to stick things to the cancer and putting radioactivity on it. Peptide receptor radiotherapy, or PRRT, is another term that people use. A lot of people will use that just to talk about this particular drug, but that's another term you can use. Radioligand therapy is a term commonly used by a number of different drug companies like Novartis. Same concept. And radiopharmaceutical therapy is another term. So all of these things are basically the same concept. Radiopharmaceutical therapy is what the NIH likes, or the FDA likes. They think that term makes more sense. So I apologize for all of the terminology out there, but there you go. Now you can say, I know all the different terms. So you look at prostate cancer going forward, this slide is very busy. And I'm not going to apologize for it. I'm going to tell you that this is actually really exciting. Each of these listings is either a diagnostic imaging agent or a therapeutic that a drug company or organization is bringing through clinical trials, hoping that will help us with prostate cancer. And so you can see all of these things. You can see the investment and the excitement that we're not only going to do well with the drugs we have, but we have a lot of things in the pipeline coming down the road. Okay, talk a little bit about the logistics. So let's say you as a patient, you have prostate cancer. Your prostate cancer lights up on the PET scan. We all discuss you and decide you're an excellent candidate for PSMA targeted therapy or lutetium PSMA 617 Pluvicto therapy, and you agree. What happens next? Well, the lutetium comes from a nuclear reactor. A company called ITM provides that in Europe, gives that to Novartis. Then Novartis takes that and they do chemistry and validation that they can link it to their PSMA radiopharmaceutical. That work gets done actually in Italy or New Jersey, hopefully in the future, Indiana. Then it gets shipped, okay? It's received early in the morning at the hospital, sometimes the day before. It flies in because these things are only live for a short period of time before we have to throw them out. They're short-lived. When they arrive, we have basically 24 hours to use it or throw it away, okay? And then we do up to 6 cycles of the therapy, kind of like chemo. So we'll give you a dose of lutetium PSMA therapy. We'll see how you're doing. We'll have you come back again later. We'll give you the next dose and we'll keep going and we'll monitor you until at least 4 doses, probably 6 if it looks like we need a few more. So how well does it work? Well, here are some examples. Here you have a PET scan in this box up on the left. This one on the left of each of these boxes is a patient before therapy, and on the right is the same patient after therapy. And what the authors did in this is they labeled on the MIP images of the PSMA PET in red all the prostate cancer lesions that they think are real and have activity. And you can see this first patient had a great response. After the course of PSMA therapy, there's no prostate cancer there. These numbers down here are the PSA in the blood. So the PSA was 15, now it's undetectable. So a complete response, best case scenario. Most patients don't get that. Obviously, we hope for that. And most patients who do get a complete response, the cancer eventually comes back. Here's an example where a patient had a lot of disease, a very dramatic response. The imaging shows no cancer detectable, but the PSA isn't completely gone. Here are some other examples you can see. So these are all examples of a really good response. These are best case scenarios. So there were 2 critical trials that drove to the FDA approval of this therapy earlier this year. One was the Therapeutic trial in Australia, led by Dr. Hoffman. And the next one was the Vision trial sponsored by Novartis, phase 3, of which we were a site of 80 sites. We actually enrolled the most patients in that trial. So if we focus on the Vision trial, this is probably more details than you want, but a couple things to pull out. It was actually 84 centers and 831 patients in total. And what they're comparing is they're saying, look, these are patients who have failed everything. They failed hormone therapy. They may have had surgery. They had to have had chemo. They've basically, they're at the end of the line. And what are our options? Well, the standard of care option is to kind of give them more of the same that didn't quite work, which is what we call standard of care. Hormone therapies, chemotherapies, or they can get that and we can add the lutetium PSMA radiopharmaceutical, okay? And so what did we find? Well, these are the 2 groups. This is how long they went before we saw their cancer grow, okay? We call that progression-free survival. So how long did we keep the cancer from growing? And the difference between the 2 is the benefit. And you can see that the patients who got the PSMA therapy went many more months than those in the standard group on average. Some of these patients had a much better response than what you're seeing here. And then we looked at overall survival. How many patients, how long did the patients survive? And again, these are very late stage patients. They've gone through everything. And what we saw was that they lived 4 months longer. That might not sound like a lot, but that is a great result in this patient population. And we're hoping, obviously, with better therapies and using these therapies in patients earlier in treatment, that we can improve upon that. Some of the other nice things from the trial said that the pain relief was significant. It improved their quality of life, and it improved their ability to do the activities of daily living, how to getting around, making their meals, going to the bathroom. The side effects were very well tolerated. The key things here were fatigue, dry mouth, because that does go to the salivary glands, so they can get a little bit of a dry mouth, anemia, which is red blood cells going down, some pain, and thrombocytopenia, which are your platelets going down. Most of those things were self-limited, and the patients did very well. Okay, so because of that, the FDA approved PSMA therapy, and they called it Pluvicto. Okay, and this is the actual FDA language. They basically said, in a patient who has failed everything, including advanced hormonal therapy and chemotherapy, who has a PSMA PET scan that shows a PSMA score of 2 or 3, so they have to be hotter than liver, they can go on and get this therapy. Okay, so what do we do in our side? Our workflow is, somebody says this patient might be eligible. Well, we go in and we dig into the record, we go through all their scans, and we decide, do we need to discuss this as a group, or is this a straightforward patient where everything looks great, we just move to therapy? If it's not, then we'll discuss it at our tumor board, and we'll discuss that patient and make sure we're all in agreement that this is the right choice, and then make the recommendation and talk with the patient. One of the things we're looking for is, not only do we want to see that the radiopharmaceutical goes to their tumors, we want to see that there are no tumors in the body that are alive and growing where the drug didn't go to the tumors, okay? Because those patients, those tumors are not going to be treated. So we're going to be very careful in looking through all of that. And then we'll meet with them, we'll talk about the safety. And I don't have time today to talk about it, but we'll talk about radiation safety. How do you make sure when you're taking a radioactive therapy, all the people around you are safe? And the key thing is, don't let anyone drink your urine, okay? If you can remember that, most of the rest of the safety things are pretty easy and of less of a concern. I'm going to talk about supply chain shortage, okay? So you guys may know, because you've got friends and you know about this stuff, you guys are so well educated. If there were friends of yours or you are trying to get PSMA therapy, you might not have been able to get it yet. You might be perfect candidate for it, but Novartis had some supply chain issues, and I'm not going to go into the details. These are good people. I mean, people in Novartis invested, $8+ billion in radiopharmaceuticals, more than half of which went to prostate cancer. They're really investing in trying to move this field forward, but they've had some supply chain issues. So we had a supply chain issue, and our pharmacy group sent me a note saying, well, we need to have a plan for how to deal with this. And they said, how much Lutathera, which is another drug, and Pluvicto, the prostate cancer, do we have in stock? Which we thought was hilarious, because as I showed you before, these things last for a day. So we have none in stock. So because of the way these drugs are made and the way they're used, they live for a few days and then they're not useful anymore. So when we have supply chain issues, it's a big disruption. We have an example of a patient came all the way from Alaska to Minnesota for their therapy, and then they get here and we find out that there was a failure of production. So we work really hard to try to make sure that we've got all that lined up. That stuff is getting better, but that is an issue. Okay, so how do we improve efficacy? What are we doing going forward? Well, some people are thinking, well, geez, we could even inject into the arteries, go right down where the prostate is and deliver the therapy prior to surgery. There's all kinds of crazy ideas out there. Combining the PSMA therapy with other therapies is also a really great idea. So we've got trials where we're combining PSMA therapy with hormonal therapy, combining it with chemotherapy, combining it with immunotherapy, where the PSMA therapy stimulates the immune response even better. Whether we combining with external radiation. So in other words, you might say, well, why would you use a drug that's radioactive and external beam radiation at the same time? Well, the reason is you can hit the tumor twice. You can get twice the therapy to the tumor, but the external beam radiation, it's injuring the tissue around the tumor. The radiopharmaceutical therapy that we do with PSMA if it's going to injure anything, it's injuring those other organs and things where you see the drug on the imaging. So it's the side effect profile is different, and you can double hit the tumor. So we're very excited about that. We're also excited about bringing cocktails of different drugs that are all radioactive, that are slightly different in terms of what they're targeting and what kind of radiation they're bringing. Okay, so how do we follow up the scan? Okay, so you've got your PSMA therapy. We want to know, how's it going? Is your cancer progressing? Well, we can image with a CT scan or an MRI or a bone scan. But as I showed you before, they're not that great. There's a lot of cancer we can't see very well. We can follow your PSA on your blood tests and other kinds of advanced blood tests, but we can't really figure out how best to use that information in every patient. So people are starting to use PSMA imaging, such as PET scans or other ones, which I'll show you in a minute, to follow up the patients, suggesting that if the PSMA drug is not going to the cancer anymore, the cancer is probably dead. Okay, so one thing that we and others have thought about, and we at Mayo and a group at Stanford and a few other places are soon following, are using a brand new technology called SPECT CT. This is different than PET. SPECT is single photon emission computed tomography. A PET scan, remember, has 2 photons. SPECT has 1. It's actually an older technology. But the cool thing about it is, with the newer digital versions of this scanner type, we can scan fast enough and accurate enough to make it worthwhile. And more importantly, instead of imaging the PET radiotracer, we inject the therapy drug and we actually image the therapy itself. So after you get the therapy, we image and prove that the actual therapy, radiopharmaceutical, went to your tumors exactly as planned and see how they're responding. So it's different than the old type of detectors. It's digital, high-tech stuff, super thin, super small. And one of the cool things about it is, as the number of photons coming out of a tumor from the therapy goes up with CZT, this new crystal, we have an almost perfect line with the amount of drug or radiopharmaceutical in the cancer. Whereas the older technology, if you have a lot of something in the target, your data just drops off. So in other words, it's better. It's just a better way to quantify how much of the therapy went to the tumors or to organs. The scans look basically the same. One of these is digital, one of them isn't. Inside the scanner, it's completely different. So the system here has the digital detector system with CZT, and it's much, much smaller. You can see how much smaller it is than the standard system. You need all this stuff to create an image out of the old system. That allows us to design scanners that focus in right on the patient. So it literally has these arms that come in. See these little things? It's really funky. So after every cycle, every injection of PSMA therapy that we do, a patient goes on this new kind of CZT digital SPECT scanner. These little arms come in and we verify that the therapy went exactly to their tumors. We get a sense of how much went to their tumors and to their organs and whether the tumors are responding. And there's 2 different companies making these. We installed the 3rd one in the world with Spectrum Dynamics, a company out of Israel that we've been working on for a couple of years now, and we're scanning our patients now. Next month, we're installing one made by GE. Similar technology, has some pros and cons, and we're working with them as well. So I'm going to skip that in the interest of time. I'm going to skip down a little bit and show you how this works. Okay. So if you go to an institution and get your PSMA PET scan, like you see here, and then get your PSMA therapy, they might send you out the door with no imaging to confirm where it went, or they might use the older scanners to just get a single, kind of like a plain, like a 2-dimensional photograph. And you can say, okay, on this 2-dimensional photograph or planar image, I can see each of these sites of cancer that were in the PET scan. Yeah, it kind of looks like the therapy drug went to each of those sites. It looks like we got them all, okay? But you can't really look and measure how much went in there. By comparison, this is what we're doing. This is a patient you saw before who's got metastatic disease on their PET scan MIP. You can see it's in their lymph nodes here, it's in the liver, it's in the bone. This patient then got their first dose of PSMA therapy. And then after the therapy, they got that funky SPECT scanner I was showing you before. And in this patient, it's beautiful. We can see each of those sites on the SPECT CT and confirm that the therapy drug went to each of those tumors, and a lot of it went to each of those tumors. And you might look at this and say, okay, well, if that's always the case, why do you do it? Well, it's because it's not always the case. Sometimes the differences between the imaging and the therapy drug make a difference. Sometimes the patient's tumor has responded to a therapy, or something else has changed between the PET scan and the therapy dose, which we make the SPECT scan out of. And then those things make a difference in how we plan the therapy. Okay, this is kind of a blow up of that same image. And this is that same patient. Now we've got, this is their PET scan before therapy. This is their SPECT scan where we're imaging the therapy itself after they got their cycle 1, and here's after cycle 2. And this is exactly what we're looking for. This is great. I see the salivary glands, the tear glands, the lacrimal glands, all of that stuff looks the same. It hasn't been hurt by the therapy. But each of these hot spots of actual tumors, they're all getting less bright or less dark on this image. There's less therapy going to them because more of the cancer cells are dying. And so that's exactly what we're looking for in these scans. So what's in the pipeline coming down the road that's going to be even better than the therapies we have? What are the concepts around that? Well, one of them is target binding. In other words, can we get more of the radiopharmaceutical therapy to the tumor? Another one is, can we use the imaging to predict how much therapy we need? In other words, we've got all this great imaging. We can actually calculate how much radiopharmaceutical went to the tumors. We can calculate how much radiation it deposited in the tumor. And so if we take that information, and maybe Mr. Smith and Mr. Jones don't need the same injected dose of therapy. Maybe Mr. Smith needs more than Mr. Jones does. And why would we put a patient at risk and give them more than they needed? Or why would we not give them enough? So that's an area of a lot of excitement. It's called dosimetry. In other words, calculating the dose specific for the patient. The other one is, can we just bring a bigger hammer? So I got this picture of a hammer here. So in other words, right now we're using lutetium as the hammer. That's what's bringing the radioactivity to kill the cancer. Well, can we just have something other than lutetium that's a bigger hammer? And yes, we can. And there's a lot of excitement about it. Can we design drugs or therapies that have lower toxicity? That's another key aspect here. Okay. Another thought here is, can we use the drug we already have? And can we use it in a different group of patients? So we have lutetium PSMA 617 or Pluvicto, and we can march it back in the continuum of care. So right now, as I said before, we're using it in patients who are at end of all their care options. They've failed everything, but it has low toxicity. In other words, people do really well. They don't have a lot of side effects. So why don't we move it earlier? So we've got the PSMA-4 trial, which is now closed for accrual, where they're trying to use it before chemotherapy, after hormonal therapy. In other words, maybe we don't need patients to fail chemotherapy to try this new exciting therapy. PSMA addition is to say, well, before chemo, and now actually at the same time we're giving hormonal therapy. Before they've even failed hormonal therapy, we want to give the PSMA therapy. There's even a group out in Germany that are doing what they call the lutectomy trial, which is cool. They're using PSMA therapy prior to surgery. And they're saying, just an initial trial to say, hey, does this work? You know, is there any evidence that this is worth doing? But to say, let's kill as many cancer cells as we can and then do surgery to see if it reduces the chance of the cancer coming back, which would be a very cool thing if that was true. Now, I've talked about how great PSMA therapy is, but it's not perfect. In general, we're not curing patients. And so I think there are some people out there, they look at the imaging that I just showed where you have a complete response and they think, doc, this is going to do it for me. This is going to get rid of my prostate cancer. And I got to tell you, I'm hoping it does, but it probably is not going to. And what can we do? Well, we can do different things to modify it like I talked about, but I wouldn't expect it to cure you. Okay. Maybe, however, if we used it early in the course of care, like I said, prior to surgery even, we could cure somebody. That's possible. Another hope is that can we use it chronically? In other words, how many cycles of this can we give. Right now, we're limited to 6, and we're not getting insurance companies and Medicare to pay for more than that. But there's good evidence to suggest that if the tumor responded before and it comes back and it's still showing PSMA activity on our PET scan, that we can treat you again and expect a good response. So we're hoping that data will come out that we can convince people to pay for it. But we could potentially treat for many, many more cycles and keep kicking the cancer back and keep kicking it back and keep kicking it back. All right. So now I'm going to talk a little bit about the bigger hammer. And I want to talk specifically about alphas. And this is kind of close to the end of the talk. What is an alpha radionuclide? Okay, lutetium is actually a beta radionuclide. It's different. An alpha is basically a bigger hammer. Okay, here are 2 examples of alpha emitters that are in phase 1 trials. One is actinium PSMA 617. So it's exactly the same as the therapy we now have, but instead of lutetium, it has actinium as its radioactive atom that gives off an alpha. Another example is a completely different structure, but it targets the same PSMA receptor on the cell surface. And here it's bringing thorium in, and that's a drug being developed by Bayer. So when this image came forth in 2016 by a group out in Germany, the whole field just got so excited, okay? I showed you before patients with lutetium PSMA showing complete responses, but not all of them do. So here you have a patient, this was in Germany during old testing before FDA approval here in the US. Back in June of 2015, their PSA was 294. This is a PET scan. You see this is cancer, cancer, cancer. There's tons of cancer in this poor patient. They did 2 cycles of lutetium PSMA, the one that we now have FDA approved. And unfortunately, their cancer progressed. You can see it's bigger. It's all in new places. It's grown on the image here. And the PSA has also gone up. So either we didn't give them enough of the therapy, maybe we needed to give them more, but we gave them, or they gave them the standard amount of the therapy that we currently give. They then switched to an alpha emitter, actinium, and after 2 cycles, the cancer is almost completely gone. 1 more cycle, it's undetectable. So this is just one case example, but you can see at least how excited people in the field are that these alpha emitters are more powerful. Unfortunately, if you look at this patient, you can see also their salivary glands. See how their salivary glands don't have activity anymore? They were nice and robust here, and now they're not. This particular therapy, as effective as it is, causes severe dry mouth that's permanent. And so as we're trying to figure out how to use these, we got to make them effective, but we also have to make them tolerable. And so there's a lot of work going on trying to figure out how to get the right balance there. So what's the difference between an alpha and a beta? An alpha therapy is bigger and more powerful and more precise, okay? Some people would say if you put it all together, it's 5 times better. But the clinical data suggests that it's even more than that. It's probably doing things that we don't even fully understand and how it's killing. And so one of the things we know that it's doing is it's overcoming any resistance. In other words, a beta therapy like lutetium PSMA, some cancers are resistant to it. Their genetics of the cancer, their mutations, their environment, they have protected themselves against that kind of radiation. An alpha kills them all, okay? So what are the difference? Again, on the left here is beta, on the right is alpha. Technically speaking, a beta is an electron shooting off of the radiopharmaceutical and killing the cancer. It goes, for lutetium, a couple millimeters. So it shoots across several thousand cells and kind of injuring them all a little bit. So you need a lot of them to kill a cancer. Whereas the alpha is more than 1,000 times more massive. It is actually the nucleus of a helium atom. So it's 2 protons and 2 neutrons. It's going to go a much shorter distance, just 2 or 3 cell diameters. So basically, it's going to annihilate the cell it's on and just a couple cells around it, okay? It's going to kill even tiny tumors, where there's only a few cells of cancer floating around, where the electrons, the beta therapies like lutetium, little tiny tumors, we just don't have a very good way to kill because the drug is shooting its electrons all over the place in the tissue around it rather than focused right on the cell it's bound to. And it overcomes resistance. And there you go. That's how you get this amazing response. So the last couple things I'm going to show you here is, one of the things we get to talk about is when you're traveling, okay? If you're getting lutetium therapies, lutetium PSMA, Pluvicto therapy, you're going to set off bomb detectors. They're going to think that you are messing around with stuff you shouldn't be messing around with, making radioactive bombs. Now, luckily, as more and more patients get this therapy, they get more used to it. Now, they know about the therapies we've done for years. We've been giving therapies to patients for thyroid cancer for years. Their detectors pick those up. They know what they are. We give every patient a little card or a piece of paper that says, I got this therapy. Please don't slow me down. Let me get on my airplane. Let me go, across the border. Let me get on the train. But because lutetium PSMA is rather new, some of these guys get pretty worked up and excited about this, and they pull our patients aside. So this here is the milliwave detector, where you put your arms up and it scans you, and this is a metal detector. Those are not the detectors that detect the prostate cancer therapy in your body, okay? It's the guys like this walking around in security with these little handheld devices, and they'll go off, and they'll be walking around, and they'll detect that somewhere in the room, somebody has radioactivity on or in them. And they'll be walking around. And I remember talking to one patient, he was like, yeah, doc, I'm sitting there, I'm going on a flight to Europe. And all of a sudden these guys start walking around in packs, and I can hear them, they're all excited, they're talking, and they start converging slowly around me. And so I just raised my hand and said, guys, I'm your guy. I'm the one who's setting it off. They warned me about this, right? And so they brought him aside, and they talked to him. I said, have you been messing with plutonium? Have you been messing with uranium? He goes, no, I had this therapy. And you get to give him this get out of jail free card. So hopefully, when you go out golfing, you can talk to your buddies about this great story you had, and hopefully it doesn't delay you, but you should plan some extra time. Okay, what else is exciting going on? This is really exciting. There's one slide on this topic. There's a huge leap forward in PET scanning coming forward. This month, we're installing the first in North America of this scanner called the Quadra by Siemens. It is a longer scanner with really high-tech stuff in it. It is 10 times better than our best PET scanner. 10 times, 1,000%. We're going to be able to see prostate cancer hiding in little tiny spots. There's another company called United Imaging Healthcare that has a similar scanner. They've got one in UC, University of California, Davis, that they're using for R&D, and they've got one up in Michigan. So these technologies are coming forward. We're going to be able to see cancer hiding in teeny little tiny spots. We can do a scan in 2 minutes of the same quality as our current, half an hour PET scans with this scanner if we wanted to. Okay, these are the last few slides. I've talked to you about PSMA. Now I want to talk to you about other targets on cancer cells, bombesin and FAPI. Here's an example of a MIP image with a drug. This happens to be a copper radionuclide for PET imaging. Bombesin is the name of the binding motif to stick to the cancer. And these little tiny dots are all prostate cancer all around here. Beautiful image, very low binding to anything else, very exciting. And this is something that we can use in multiple kinds of cancers. It's not just prostate cancer. Here's another one we're excited about. We're doing quite a few trials. I actually I'm a co-author on an NIH grant looking at this one. This is called FAPI, or fibroblast activated protein inhibitor. It's also a pan-cancer, although it has multiple cancers. This is a prostate cancer patient. All these little dots are radiotracer going to the tumors. The interesting thing about this one is that it doesn't bind to the cancer cells itself. It binds to the body's cells responding to the cancer. So all the scar tissue the body makes around the cancer cells, trying to wall them off, is what it's sticking to. And it lets us see cancers we otherwise can't see. So with that, thank you so much for your time. I'm delighted to be part of this. Again, to all the prostate cancer patients out there, we are in this together. And I hope this clarified and explained some things for you as you figure out what your next steps are.